cancer, and there are a lot of questions which I personally have in mind. Or if you have any questions which you want to ask Dr. Girish while he is here, feel free to ask. Thanks a lot, Dr. Girish, for taking time out. Over to you, Shrenik, sir.
Right. Very warm welcome, Dr. Girish, sir, and good evening. Well, my voice is my identity, and this is kind of a lifetime. I would say this is my lifetime fixed asset. So I would love to welcome you on board, friends. When it comes to blood cancer or even thalassemia, in most cases, people get scared and they definitely feel like it's kind of going to be an end of life. And that is where Dr. Girish is there to look after things and bringing the hope beyond any imagination. And he is one of the best medical oncologists and hematologists with a huge experience, and currently is associated with the SCG Manavta and Nashik. And I would love to welcome Dr. Girish sir once again. Welcome on board, sir, and thank you so very much for your time.
Thank you, sir.
Thank you, sir.
Thank you very much for having me on this show. I thank Shrenik sir, and thank you, Mr. Ravi, for having me here.
Most welcome, sir. So we have a lot of questions about the topic, but before we get started, we want to hear about you. People want to know Dr. Girish well. So if you can share a little bit about your journey, how you have provided services, and about your healthcare experience.
Girish, and I started my journey from Grant Medical College, where I did my M.B.B.S. From Grant Medical College, I joined my M.D. in Lokmanya Medical College in Sion, so that is popularly known as Sion Hospital. And then during that time, there were only 4 seats across India where we used to get training in hematology. And so I pursued my training in hematology at Institute of Hematology and Transfusion Medicine at Kolkata. Popularly, it is the first medical college in India.
Okay.
And then I had my brief training with bone marrow transplant, and I joined HCG Bangalore, where I started doing bone marrow transplant and treating hematology and hemato-oncology patients. I have worked there, and then with my team, I did close. Being Maharashtrian and from this part of India, I chose try to serve the tier transplant and creating a transplant center. So I came here, I joined, and last 2.5 years I am working with HCG Manapa Cancer Center. We have done more than 30 transplants so far, and definitely with very good outcome. And most of the patients are from very, I will say, very non-affordable kind of background, where we got helps from various organizations and government agencies for the transplant, and we're trying to do transplant at probably at a reasonable cost, where definitely when it comes to transplant, every first thing comes to the mind, what is the cost? So we're trying to do it as much as as reduced as possible, and definitely there are agencies which are helping us to do it. And we have our patients from peripheral parts of India and from very small villages where they haven't heard about transplant, but then they had to undergo the procedure, and they were searching for the institute and right place to do transplant, where we could provide some solution over here and trying to expand it as larger as possible and make it as affordable as possible to most of the people across this part of the region as well as India. So this is all about me. I think my BMT being my passion and hematology being my passion, I'm trying to do as best as possible and as possible to serve the patients and the society with best of my capacity. Thank you, and thank you again for having me over.
Super. Thanks a lot, sir. So those are the claps from Shrenik, sir. So my first question: what is bone marrow? And when we talk about bone marrow cancer or bone marrow transplantation, how does it start? A lot of people might not be aware of this term bone marrow. So if you can explain that in a layman term, as a common man who doesn't understand, medical jargons.
So bone marrow, as we popularly know, so we have blood in our body and we have three major cells. One is RBC, that is a red blood cell, white blood cell, and platelets. So where does this blood come from? And it comes from the bone marrow. So bone marrow basically is a factory where the blood is produced, and generally it is produced in the flatter bone of the body. At birth, most of our bones are producing blood. As we grow, the flatter bones, especially our pelvic bones, have being the major source of blood. So bone marrow essentially is a part or a central part of the bone where the blood is produced and ultimately reaches our vessels and circulated by our heart all over the body. So bone marrow produces your RBCs, WBCs, and platelets. Along with there are some other stromal cells. There are different type of WBCs which are produced, and it's a continuously functional organ. It keeps on functioning throughout the life, the way our heart functions. So bone marrow, though we are not very much aware, but it's a very essential organ, and it produces the blood.
Okay, sir. So when we talk about blood cancer, where does that originate? Does it originate from the same location? And what is it? How does it start?
Right. So now, when we say blood cancer, it's a very large term, and it includes many types of cancers. And if the cell of origin, if you say, it originates from the stem cell. So stem cell is a cell which is in the bone marrow. So basically, when we say bone marrow transplant, it is essentially a stem cell transplant. So these are all same terms: bone marrow transplant or a stem cell transplant. It is one and the same. So stem cell is the basic cell. It's a mother cell from which various types of cell are produced. Your RBCs, WBCs, platelets, and many other stromal blood cells are also there. And these are the stem cells which produce ultimately your blood. So if you think when the stem cell get damaged, when there are some genetic damages or some environmental factors which play a role, when this stem cell get damaged, it starts functioning improperly and it replicates and then it produces cancer cells, which ultimately comes into the blood. So this term blood cancer, basically it includes multiple cancer like acute leukemias, there can be multiple myelomas, there are lymphomas, and a lot of various varieties of diseases which are actually been coined as a term called as blood cancer. But actually it's not a single disease, there are many diseases and there are different treatments. Most of them are curable, some are very catastrophic, some are very indolent. Indolent means very slowly growing. Sometimes people just live with the cancer without any problems, the way most of the patients live with diabetes and blood pressure.
Dr. Girish? Okay. Yeah, sorry, we lost you for a bit. You're back.
No.
Yeah. So I was about to ask you, is blood cancer curable? So I think you were responding to that. So yeah, because movies में हम लोग देखते हैं कि एक बार blood cancer आ गया, so that is the end of it. So you were responding to that. So is it curable?
So now, frequently, whenever we give the diagnosis of blood cancer, the first thing is, oh my God, so it was thought to be a death sentence, but it is not true, entirely true. There are certain cancers, acute leukemias, like acute lymphoblastic leukemias in children up to age of say 6 to 10 years of age. They are 90% of them are completely curable if you start the treatment at the right time. Then there are certain lymphomas which are absolutely curable. Then there are uh, different types of chronic leukemias which are actually curable. So there are many cancers which are curable, but there are certain cancers, as I told, cancer has become a chronic disease nowadays. It is not a 100% non-curable entity or a feared entity now. Most of the cancers can be controlled and they can be kept under control for the lifelong period. But there are certain cancers which can be little more aggressive and they need immediate care, and when the stage of the cancer grows out of proportion, they generally become non-curable. Though not all the cancers are curable, there are certain cancers which are definitely curable, there are certain cancers which are mostly curable, and there are certain cancers which become non-curable eventually. So, though the percentage is gradually coming down, so more than, I will say, 70 to 80% of cancers are definitely curative.
So, sir, the next question, does all the blood cancers need, bone marrow transplantation? Is it one
Right.
treatment for everything, or it's?
Okay, yeah. So bone marrow transplant is though a curative option, but it doesn't mean that all the blood cancers require bone marrow transplant. Initially, all the cancers require chemotherapy, and once the chemotherapy is done, there are certain cancers which are in a higher risk category. As I was explaining. So those typical cancers like say AML, acute myeloid leukemia, which are intermediate and high risk group, those patients definitely need bone marrow transplant for cure. Then there are certain myelomas where, though it's not a curative treatment, but it increases the disease-free survival. Cancers which are indolent, which are slowly growing, though they relapse again and again, but what in such cancer what we need is disease-free interval. So the longer the disease-free interval, patient will have a good quality of life in a longer run. So bone marrow transplant in such situations will help a patient to live a disease-free life for a longer time. And then in certain lymphomas where there are relapsed lymphomas where we have to go ahead with bone marrow transplant, which is generally an autologous bone marrow transplant for myeloma and relapsed lymphomas. In acute leukemias, then there are certain refractory lymphomas where we have to do allogenic bone marrow transplant. So essentially, it is not a curative treatment for all the cancers. There are certain variety of cancers which have become refractory or which have a tendency of relapsing in spite of giving chemotherapy. In those situations, we offer the patients a bone marrow transplant.
Okay. So which type of hematological cancers, what are the various type of these cancers available right now?
Cancers which are, yeah. So basically hematological cancers like acute leukemia includes acute lymphoblastic leukemia and acute myeloid leukemia. In acute lymphoblastic leukemia there are two varieties. One is a B cell and T cell. So those with T cell generally are being aggressive, and in AML there are some aggressive varieties where their patients are classified into intermediate and high risk group. In those patients, definitely the patients require bone marrow transplant for cure. Then there are certain diseases like multiple myeloma where autologous bone marrow transplant is absolutely necessary in the when there are patients who are younger patients in the age group of say 40 to 50, because in India, the myeloma happens. Recently, we know a famous actor has got diagnosed, and there are a lot of other famous actresses who are having multiple myeloma, and they have undergone bone marrow transplant. So, multiple myeloma is a disease which has a very relapsing pattern. It gets under control, again it relapses, it gets under control, again it relapses. So, in such situations, autologous bone marrow transplant does give patients a fair, disease-free life. So, in multiple myeloma, it's a very important option. Then, in relapsed lymphomas, where post chemotherapy the patient relapse after 2 years, 3 years, or sometimes earlier as well, in those patients, definitely a bone marrow transplant become a curative option. Then there are certain uh, uh, diseases which are more aggressive, T cell type of lymphomas. In those situations, sometimes we have to give upfront treatment option. Then in benign conditions like aplastic anemia, where it is where the bone marrow fails to produce enough blood cells and the patient always have deficiency of hemoglobin, WBCs and platelets. In such situation, a bone marrow transplant can completely cure that patient, and the outcomes are very fantastic in those patients.
Thank you, sir. So we do have some people joining in and asking questions. We have Shushma Gandhiji who is asking a question. How to improve HP? I am thalassemia minor or minor and taking hormones therapy.
Okay. So thalassemia minor essentially is not a disease, it's a carrier state. So basically what happens in thalassemia is it has been passed from one generation to another, next generation. So if both the parents are minor, then the chances of a kid having thalassemia is around 50%. So those situations, thalassemia minor essentially is not a problem. It's not a disease. It is just a carrier state. Probably, if the hemoglobin remains low, you need to check your iron levels or other vitamin levels. If those are deficient, definitely those iron supplementation and vitamin supplementation might help improving your hemoglobin.
Okay. So, what exactly is thalassemia? Since we are talking about it, we've done a couple of blood donations for thalassemia. ये मालूम है कि they really need blood regularly, but how does it occur? What is the background behind it? Maybe we can spread some awareness on that.
Yeah. So thalassemia is basically a hemoglobinopathy. It's a disease of hemoglobin. It's an abnormal hemoglobin which is produced. So there are two chains, beta and alpha chain in the hemoglobin, and this beta chain gets defective, and it causes beta thalassemia. So now there are two, probably I will say three varieties: thalassemia minor, thalassemia intermedia, and thalassemia major. So thalassemia is passed from parents to the kids. If both the parents are say thalassemia minor, then the 25% chances of kids being thalassemia major, 50% chance being their carrier, and then their 25% can be normal. So it is basically been a genetic disorder which is passed from parents into the kids. So this is a hemoglobinopathy, and where the patients need continuous blood transfusion support to sustain the hemoglobin levels. They have a very low hemoglobin, and it generally gets detected in the first year of the life, where the infant start requiring blood transfusion, and they continue to get the blood transfusion at a regular interval, sometimes every month, sometimes twice in a month. Sometimes the frequency can go higher as well. Sometimes they need every week. So this is a very kind of a dreaded disease, and it is a preventable disease. So if you check at the time of marriage whether the patient, whether the husband and wife both are being tested, and if they are thalassemia minor, then probably they can think about it, or they can do prenatal testing, and then if it's a thalassemia major kid, probably they can avoid that pregnancy as well. So this is basically a preventable disease, because we know how it is passed on to the next generation. So it is, as the awareness grows in the probably college going kids, they can get themselves tested. More and more screening programs happen, and we try to test the thalassemia carrier or thalassemia minor patients, and we can avoid those kind of marriages where both the kids, both the husband and wife are not thalassemia minor, and if one is normal, then definitely there is absolutely no chance of having thalassemia major kids. So it is basically a preventable disease, and there are many organizations which are working towards this prevention thing, and there are a lot of screening programs going on. But those patients who have developed thalassemia major, for them the life is little difficult because they require transfusion, they require blood, they require chelation therapy. There are other complications of regular transfusion because iron overload is there. There are hormonal issues. There are bone problems. Then there are a lot of growth issues for them. Averagely, with transfusion, the thalassemia patient can live up to 40 to 50 years. But they need to definitely a regular transfusion and very good other support as well. They need good chelation therapy, which are basically very costly, not that every Indian can afford it. So things become very difficult when thalassemia major kid is born in the family, and then supporting that kid's transfusion and other treatment economically can be a huge burden on the family.
Okay. So is thalassemia curable with bone marrow transplantation? Is it possible?
So yeah, so what we essentially do is when thalassemia patient is diagnosed, mostly the transplant is needed only and only for thalassemia major. So definitely it is not required for thalassemia minor patient. They are not at all, this is not at all a disease. It is just a carrier state. So they don't need, it is required only for thalassemia major kids. And the success of transplant in thalassemia major kids below 10 years of age is excellent. And yes, it is curable with bone marrow transplant if it is done at the right time. And if you have a family matched sibling donor, if the patient's siblings are matched with the patient with HLA typing. So generally we try to do HLA typing of every thalassemia major kid and try to find whether there is a match in the family. If the match is in the family, those are the kids should undergo transplant on the priority.
Okay. So we have one more guest joining us, Vanaja Ramisetti. She is saying good evening, Dr. Girish and Ravi. So thanks, Vanaja, for joining in. She's asking how much does it cost for a bone marrow transplantation, sir?
Okay, so for bone marrow transplantation, the average cost for allogenic bone marrow transplant is around close to 12 lakhs. And then there are certain variety of transplants which can go up to 20 to 25 lakhs, depending on the donor availability. And sometimes it can go higher also if you are arranging the donor from abroad. If you don't have a family donor and you need to get the stem cells from some other donor outside the country.
Okay. So how is bone marrow transplantation done? I mean, practically, physically, what is the process of, doing it?
So if when we say transplant, so everybody thinks it must be something like operation which is done for liver, kidney. So this is not at all. There is no operation involved in bone marrow transplant. It is the only transplant where there is no surgical procedure. It's a medical procedure. So what we essentially do, as I told you, bone marrow transplant is essentially a stem cell transplant. So nowadays we try to collect the stem cells directly from the blood with the help of apheresis machine. It is the same machine which is used to collect the single donor platelet. We all know how single must have donated the single donor platelets. So you are connected to a machine which separates your platelet and collect it in a bag.
Right.
So same way the stem cells are been collected with the help of apheresis machine, and it is collected in a bag, and it essentially looks like any other blood bag. So what we first do is the stem cells are collected from the donor. Then there is chemotherapy which is administered to the patient. A patient undergoes a very high dose chemotherapy where his stem cells are completely wiped out. So his bone marrow becomes essentially empty. And what happens is we have to collect the stem cell from the donor, and then these collected stem cells are given back to the patient. And these stem cells go in the patient's body. They go and home in the bone marrow. They find their home, go to the bone marrow and try and start producing the blood the same way it is produced in the donor. So the blood of the patient becomes a blood like a blood of the donor. So if the blood groups are different, suppose a donor is A positive and patient is B positive, then the blood group also changes. The patient's blood group changes like donor. So basically, his blood becomes like a donor. Uh, why we need to do this? Because there is something called as immunity against the cancer. So now when we give chemotherapy, it is basically the toxic effect of the chemotherapy which kills the cancer. But then there is immunological killing. So the immunity of the donor becomes patient's immunity, and it kills the cancer because it's a strong and good immunity. Why does cancer happen? Cancer happens because there is the immunity of the patient's body is not able to take care of the cancer. So now we are giving the patient a donor's immunity, which is a healthy immunity, and this immune cells of this donor will control the cancer, and it ultimately not allow any recurrence. So that is essentially known as uh, graft versus leukemia effect in a medical term, because this graft is this donor cells and leukemia. So these cells are immunologically killing the cancer cell, and they will not allow the growth of cancer cell in the future. So that is how it completely cures the cancer.
Okay.
So it's a medical procedure. It is basically collecting stem cell and just infusing, transfusing it the way we transfuse the blood.
So then, can't we do this for every cancer, category where you're completely infusing
No.
new
This is
blood?
mainly practice for blood cancer, not for other cancers, because what happens is it was tried for the breast cancer and other, but it hasn't shown a very great response for those cancer. It is essentially because it helps stem cell being the basic cell, as I told, for blood cancers. So basically we are trying to replace the basic cell. Stem cell of the donor becomes stem cell of the patient, so the defective stem cell is gone. So basically it helps in the cases where the stem cell is a defect.
Got it. So we have another question from Vanaja Ramreddy. What is the survival chances of blood cancer in kids?
In kids, I told it is around 90%. In cases like ALL, where chemotherapy itself can cure almost 90% of the patient, and we have so many kids surviving, and then they grow and they come back to us with their degrees, and probably they're getting admission in some institutes. So it's a very the patients which I have treated during my DM days are calling and sometimes telling that they're still doing good. So outcome in the patients, pediatric patients are very excellent. Almost close to 90% of them survive and lead absolutely normal life.
Okay. So Vanaja has another question. She is saying, what kind of screening tests to be done for thalassemia? I think she meant for people or the spouses, or for somebody to check whether they have thalassemia or not.
See, the direct test, I have to say it's HB electrophoresis, hemoglobin electrophoresis, which or HPLC. So this test directly detects whether the patient has thalassemia or not, whether the patient is thalassemia minor or major, or if at all, if normal. So if we do that test, generally we get to know the answer. But the issue is most of the villages and peripheral parts of India do not have access to HPLC or electrophoresis. In those situations, what we can do is simple tests like CBC, complete blood count, and try to see whether there are some whether the hemoglobin is low or not, and there are certain parameters which can be checked, which we teach most of our general practitioner and nursing staff how to read that CBC, and we do a test called as LDH. If that LDH is high, probably we are likely these patients should undergo HD electrophoresis and try to rule out thalassemia minor or thalassemia major. So
Okay.
these are basically few screening tests which we can do and diagnose a case of thalassemia.
Okay. So another question: if the stem cells of a person are already stored, can they be
Okay.
used, doctor?
Yes, definitely they can be used, but then there is no way we can actually. There are no such banks which will just store those kind of stem cells. There are cord blood banking, but they are for individuals. It's not a public cord blood banking like in the Western world. So in India, probably we are going to have, or there are few agencies which are starting public cord blood banking where we can mix 2-3 units and then have adequate dose of stem cell for the bone marrow transplant. A single unit generally does not suffice, so we need to pull them, mix 2-3 bags, and then infuse that stem cell to the patient.
Okay. So as a donor,
But
let's say, for example, if I'm healthy and I have healthy stem cells, I'm ready to donate. Does the cost of
right.
the overall procedure reduce, or it
Mhm.
remains still remains the same?
That is like autologous bone marrow transplant. You are using your own stem cells for yourself, but then if the stem cells are defective, see, generally cancer happens by two-hit mechanism. So first hit has happened somewhere, and then a second hit happens, and then the patient develops cancer. So probably there has to have some defect to begin with. If a person is developing a cancer, there has to be some defect in the stem cell. So probably we cannot do use same stem cells for doing the bone marrow transplant and preserving them for so long. We don't know whether applicability is whether a person is going to develop cancer or not. It is very difficult to say. It might just go waste, and it's very cost intensive to store those stem cells for years together because you need a cryopreservation, you need a good amount of storage. So doing that will be little difficult.
Doctor, yeah, can you also elaborate about GVHD? This is a new term. Yeah.
Right, right, okay. So essentially, before I talk about GVHD, I'll tell you what are the complications. It is because GVHD is one of the complication of bone marrow transplant. So what we do is we have wiped out the stem cell of the patient. We have collected healthy stem cells and we have given back to the patient. Now these stem cells of the donor are basically graft, and the host is the patient. Patient is the host, and the donor stem cells are the graft. Now these stem cells go into the bone marrow and start doing their function. Their function is to produce the blood. So now what happens is there is always a dilemma. Now the patient's body feels these are not my cells, so they will try to reject it. And these infused stem cells which are coming from the donor, they will feel okay, this is not my body. They feel this is not my body. Probably I have to attack. This is some foreign body, so I cannot stay in this body. So they try to attack. So the attack from the stem cells on the patient's body is called as graft versus host disease. So these stem cells which are coming from the donor are graft and patient is host. So these stem cells attacking on the patient's body is called as graft versus host disease. Now these stem cells essentially attack the skin, liver, your GI tract, that is your alimentary canal, and then it can attack various parts of the body. So basically these three organs are very crucial in the initial phase. So this is called a GVHD. So GVHD, which occurs within the first 100 days post-transplant, is called as acute GVHD. And the GVHD which happens after that is called as chronic GVHD. So chronic GVHD happens, can happen up to 2 years. So it's a recurring, it's a kind of a chronic disease. That's why it's called as chronic. And acute is very dangerous. Sometimes we lose life because of acute GVHD. It can be very dangerous. There can be risk of liver failure. Then there can be severe grade 4 GVHD, which can happen in the GI GVHD, skin GVHD. The skin can completely become charred. So it's a very dreaded complications of bone marrow transplant. Along with that, there is chances of developing infections because patient does not have immunity. Till the time these stem cells start working, there is a period between almost 15 to 20 days where patient will not have any immunity because the stem cell have to produce the blood. By the time the factory starts, there are no cells in the body. So patient will not have any immunity. And once these neutrophils start coming into the blood, they will give the immunity. Once that number increases, gradually patient feels better, and then when it becomes almost normal, we discharge the patient. But this whole process takes almost 20 days or more than that sometimes. So that's a crucial period where patient can have various infections. There can be bacterial infections, fungal infections. Then there are some difficult viruses like CMV, adenovirus, so which can definitely adds to the mortality. So these complications are very difficult. So that's what I have explained, GVHD and then infective complications which can happen during the transplant.
Okay. So, what is hapla identical transplant?
Right. So now transplant requires HLA typing. So what we do, how do we select a donor? What we do is we check patient HLA, we check donor's HLA, and if they match completely, then it becomes a full match transplant. When they do not match, now what happens is now earlier the families used to be very big. So every the kid used to have 4 or 5 brothers or sisters, and then there were a lot of options. If you have 4 siblings, the chances that you have your family donor is almost 25%. But now if you have only, now the family size is shrinking, we have only one sibling, the chances of being matched is less than 10%. So when we do not have a donor in the family, what we need to do is we have to choose a donor which is half match, because half of the genes are coming from the mother, half are coming from the father. So the siblings will not have a complete match, they will have half match. Or if you have to choose mother or father as a donor, then they will obviously be half match. So a half match donor transplant is called as haploidentical bone marrow transplant.
Okay.
When
So
we don't have a full match donor.
okay. So generally kids are like either, they look like mother or they look like a father. So, does the looks have anything to do with it, or, the genetic, this thing is completely different than the way they look, or then the way their nose and eyes match?
It's just looks don't matter. So though they are looking like mother or father, they have taken the facial features, but not essentially the genetic features. Half definitely come from mother and half has to come from father. So we have to do HLA match, and then we can decide whether there is half match or full match. There are sometimes lucky situations where you can find a complete match between the parents as well.
Okay. So, any side effects for the donors, for doing this?
Donors, right. So yes, as first thing in medicine, when we are taught, is do no harm. If you cannot do good, at least you should not do harm. So yes, there is no harm to the donor. It's a completely safe process. 99.9% of the times, patient donor do not have any complication. He has to undergo a procedure called as catheter insertion. So it's essentially to collect that blood so that he can be connected to the machine. So that is the only painful procedure he has to undergo, and he has to take some injections so that his stem cell come from the bone marrow into the blood. So he might experience some kind of a body pain. Apart from that, there are hardly any complication. It is almost a safe procedure. The way people donate their platelets, it's the same way they donate their stem cells.
What is mud transplantation?
Yeah. So mud transplantation now, since when we don't find any donor in the family, now we have an option of doing haploid transplant, and we have an option of doing unrelated donor transplant. So mud stands for matched unrelated donor. So it is completely matched, but he is not related to the patient. So this his HLAs will be identical, and he can have less of complications when he gets the donor. So what we have to do in such situation when we don't find a donor in the family, we approach various stem cell registries. There are a lot of Indian registries as well as uh, abroad we have international registries as well, which every patient has access to. Our Indian patients have access to all the registries, and all the patients across the world have access to all the national as well as international donor registries. So what they do is we have to register yourself as a donor. So whenever they will take our blood, they will check our HLA, and they will keep it in their data. And when a patient approaches a donor registry, they hand over their HLA to the registry, and they try to find out whether there is any match. If they have a match, they intimate the doctor and the hospital about the match, and then we can approach the registry for donation and procuring that stem cell for the patient. So basically, it is from the registry where we get the stem cell. It might be Indian registry as well as international registry.
So, as a common man, can I go ahead and volunteer and register? Because this seems to be life
Absolutely.
saving, and
Yes,
I'm B
yes,
positive,
absolutely.
so all I know is I'm B positive. I've done a couple of blood donations, including for thalassemia. So I can
Right.
go and volunteer and check this out and register myself without any issues.
Yes, 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 yes. You can approach, you can go there on their site, you can register yourself, and then you need to give your sample for the HLA typing, and you will be one of the donor registered in the registry.
Well, this is very good information. I think everybody should register because
Yes,
there
yes,
might be
yes. More and more
one
of us should
person who
register.
really needs this, and it can be life saving for them without much of
Definitely.
delay.
Yes,
Uh,
yes.
so
It's truly means what I'll say, selfless donation. There are no returns expected, and it's completely been the patient does not know from whom he has got the donation, and even he doesn't know where it is going. So
that's
both are unaware of from the source is unaware, and the destination is also unaware from where exactly it is coming.
that's really nice. So Shrenik sir, any questions from you?
Uh, not really, but when let me speak for a while. What exactly and why we are here for this series? As a matter of fact, we have we are other. This is our 16th episode. Uh, From 15th episode, we did a quite good number of sessions pertaining to the various type of cancers. I must say that well, we are certainly open for inviting other specialists to cover other disease, but one of the key reasons of trying to start and continuing by inviting cancer specialists is, cancer is spreading like anything, and at times survival rate, etc., are going down. So basically, the key purpose is like what Dr. Girish said, that this is absolutely precise information being made available on the basis of knowledge, experience of many years. And this kind of information cannot be made available so easily on any web browsers, and even if it is available, it takes its own time. So and again, this information is being provided on the basis of their experience of years together. So, honestly speaking, neither me or Ravi, we are not doctors, but still we are having a privilege and pleasure of inviting such super specialists for one simple reason, that we would like to provide a kind of support to the community for early diagnosis, timely treatment, and possibly to lead a better life, and increasing the survival rate. And believe me, today's session is absolutely spectacular because as I said at the start, when it comes to the name of the disease, leukemia or blood cancer, the first and foremost thought coming is end of the life. So we through our platform trying to provide support to this medical oncologists and the specialists to the community, so that they can be reached out in a real time. And we try to become a bit small. We perform a very small role of catalyst, as a catalyst, that we could do something for the community. So this is my take. And I must say that the information provided by Dr. Girish is, I mean, incredible. I don't think that anybody can find it so easily, so reliable, and so dependable on any type of web browser. And even if you find this information on web browser, still you are stuck up with have information. So this is a very precise information provided. On the other hand, apart from question, I have one small request to the all community, all attendees, that please look into one of my requests on Facebook. There is a patient, Kriti, in Rajasthan. She is 22. She is battling blood cancer, and she is actively looking for a donor match. Kindly go to my Facebook page and click on the link and try to register. As Dr. Girish has said, you will be playing a key role in saving someone's life, which is needed very badly. And yes, we are certainly committed to bring more and more such super specialists, particularly from oncology field, for a simple reason. Like we would like to provide support to the people, and that's it. And again, this is the topic oncology, which is close to my heart, because I know what was cancer, what I had gone through, and what kind of life I'm easily able to lead, simply because of all these cancer specialists. So I salute the dedication, and I really have no other words.
Yeah. Thanks a lot, Dr. Girish, for taking time out and sharing these insights. Very detailed, very insightful, very simple to understand. I think a layman who doesn't understand these terminologies also will be able to understand the way you have explained. So it's an honor having you here, sir, on the show. So viewers, we will share the social handles where Dr. Girish is available. Also, most importantly, as Mr. Shrenik sir has mentioned, do your bit. Please do blood donation frequently, especially for thalassemia, because they have no other option but to have frequent blood infusions. And apart from that, yeah, if you can, go ahead. I will explore as soon as this show is done. I will explore where I can register for a stem cell registration. I think I should, and everybody should go ahead and do that. So, Shrenik sir, yeah.
So just one question. I mean, in a Western country, nowadays, the cell therapy is becoming quite popular. So, what are the probability in India? I was told that T-cell therapy is so much expensive. So, if you can just pretty much provide.
So it's called as CAR T cell therapy. It's a chimeric antigen receptor CAR T cell. So CAR T cell therapy, yes, as you said, it is cost is quite high, almost costing some 2 to 3 crore in Indian rupees. But yes, there is research going on in Tata as well as some private institutions where the scientists and the doctors together are trying to get the same technology in India, and probably soon, though it will take some time because it's quite complicated. Getting it in India at affordable cost will be definitely a challenge initially. But once it comes to India, probably it might take some years. But definitely, it is. There are research and people are working together to make it possible for Indian population as well. So though it is not available right now, but it will be soon available. The progress is we are inching to get that technology in India as well.
Thanks to all the
Thank you,
efforts.
thank you. Thank you, thank you.
Thank
And friends, one more point I would like to emphasize, which I am doing in all my sessions, is particularly in the field of oncology. I believe that the Indian oncologists are at their best all the time and truly being human. If you really don't have a fancy of spending money like anything, or like telling to the people that I got my treatment done in New York or London. I mean, you should continue, or you must get the treatment done in India. These oncologists are at their best, and once again I would say they are truly being human. Thank you so very much.
Thank you very much, Shrenik sir. I think on behalf of all the oncology fraternity, I think I should thank you for those kind words. And thanks for having such a trust on the Indian medical system and Indian oncologist. Thank you very much. And thank you for having me in this health talk show with
Thank
My
you.
pleasure, sir. My pleasure. Thank you once again.
Thank you, sir.
thank
Thanks a
you.
lot, Girish.
Thank
Dr. Girish.
thank you.
Yeah.